Good afternoon. Really excited to welcome you to the postgraduate course this afternoon. And I'm hoping for really great attendance since the weather's really bad. So thanks for being here. We have an expert panel of really engaging speakers on their specific topics. We're covering the whole gambit of surgery, from colorectal surgery to liver surgery to breast surgery, and then finishing it off with some palliative care and how that relates to all of us. My name is Virginia Schaefer. I'm the moderator, and I'm happy to introduce our first speaker, Dr. Seth Rosen. He's an associate professor in the Division of Colon and Rectal Surgery at Emory University School of Medicine. He graduated from Emory as an undergrad and then went to NYU for medical school and then completed his general surgery training at University of Chicago and finishing off with his fellowship at Cleveland Clinic in Florida. He's been in practice since 2002, so he lends us a depth and breadth of experience. So welcome, Dr. Rosen.
Can I rest my tea here? When Dr. Schaefer says I have depth and breadth, she's saying I'm old. That's Dr. Schaefer speak for that. So thank you so much for the invitation. I'm going to try and, obviously if my topic is controversies in colon and rectal cancer, that's a little bit broad. So I tried to narrow it down a little bit to controversies in just colon cancer and specifically just locally advanced colon cancer. As a colorectal surgeon, I can't spit without running into somebody who wants to tell me about a new study on rectal cancer. So I'm kind of tired of rectal cancer. I'd like to talk about colon cancer a little bit. These are my disclosures. So what exactly do I mean by a locally advanced colon cancer? Basically anything that's T3, deeper, T4, or anything node positive. So not T1s or early T2s and not stage 4 disease. And why do I want to focus on these? This is about 40% of the patients we see with colon cancer. You can see their survival is much worse than the early stage colon cancers. And frankly, as surgeons, for these 40,000 patients, I think we do a great job with the stage 1s. I don't feel like I have a whole lot to offer in the operating room for the stage 4s, but for these advanced stage 2s and stage 3s, I feel like we can do a lot better than we're doing perhaps. And maybe we can move that curve a little bit. So I'm going to focus on 4 topics, and I'm going to, really hit these pretty quickly. This is not going to be a comprehensive review of the literature. I'm just going to give you some key points. I did do a comprehensive review of the literature, and I'm going to give you some key points that I saw. Number 1, on minimally invasive surgery for these patients. What is the role of CME, or complete mesocolic excision, for these patients? What's the role of neoadjuvant therapy for these patients? And how are we doing with preoperative imaging, which is essentially CAT scan? So let's focus on the MIS question first. In the 2000s, there were a series of large randomized controlled trials that basically asked the question, is laparoscopy okay for colon cancer? And the answer was, yeah, it's feasible, it's safe, and it seems to have equivalent outcomes with open. But these were highly selected patients and frankly, highly selected surgeons. And, is this generalizable to the overall community? The studies often excluded large tumors, these locally advanced colon cancers. For example, the COST trial only had 12 patients with T4 lesions. The locally advanced colon cancers, as you'll see, these are more likely to get converted. They often require multivisceral operations. And these patients that can get converted, they tend to do worse. So for pretty much a long time in the United States and in Europe, it was recommended do not use MIS for T4 cancers. We don't have data to support this. Here's a meta-analysis that took all the data from those trials, put all the data together, so about 1,400 patients, 1,500 patients, and said, how are we doing? And I would first point out that the lymph node numbers were equivalent, and they were only 12. The margins were equivalent, the survivals were equivalent, whether you looked at stage 1, 2, or 3. No significant differences for recurrence, and they did point out that there was about a 19% conversion rate for the laparoscopic group. So yes, laparoscopy is okay for colon cancer, but really all these studies excluded advanced T3 and T4 patients. And so we don't have great data supporting that. Here's long-term follow-up from one of those trials, the classic trial. We have data from 10 years ago, and I just pulled out the colon cancer patients, not the rectals. And again, no difference in local or distant recurrence, no difference in overall survival. However, there is a trend favoring open, and there was a trend favoring open for stage 3 patients. And so one of the things they also pointed out in the discussion was the patients who did the worst were the ones who underwent conversion. So the laparoscopic to converted group had the worst overall survival. And so they concluded, yes, laparoscopy is safe and suitable for these patients, but the converted patients appear to do worst, and the locally advanced colon cancers are the ones that are highest risk for conversion. Here's a meta-analysis just looking at T4 colon cancers. Again, about 600 patients, lap versus open. No differences in overall survival, disease-free survival, or positive margins. Again, a high conversion rate. And in this article, they had an interesting discussion on, what conversions can be different, right? You can have a strategic conversion. You put a laparoscope in, you look around. After 5 or 10 minutes, you go, nope, this is not a good case for this. Let's go open. Those patients probably do similar to the open. It's the patients that you're in there for 4 or 5 hours, you're getting into bleeding, you're getting into the wrong planes, and then after 4 or 5 hours, you convert. Those are the patients that tend to do the worst. So their conclusion, yes, laparoscopy is okay for T4 lesions if you have gone through your learning curve, essentially, and then you should have similar oncologic outcomes as open surgery. Here's a cancer data bank review of T4 colon cancer management, and this is more recent, so it includes the robotic patients as well. This was propensity score matching about 800 to 900 patients in each group. If you look at the bottom of the slide, you'll see that the short-term survivals were better in the MIS group. They got to chemo quicker. The lymph nodes were better in the MIS group. And looking at the robotic versus lap, less conversions in the robotic group. And when they looked at survival, both the robotic and the laparoscopic had improved survival, about 25 to 33% improvement over the open group. So their conclusion, you can get improved lymph node harvest, shorter time to get to your chemo, decreased mortality, and robotic seems to be converted less often than lap, almost half the rate. So I'm going to move on to the second area of discussion, complete mesocolic excision. The Japanese surgeons have been doing D3 resections since the 1980s. And in the 1980s, we had TME introduced us for rectal cancer to lower recurrence rate from the 30 to 40% down to single digits. Can we achieve something similar for colon cancer? And so a group in Germany published their initial works on this in 2009, and then others have followed. When you look at the literature on this, it's mostly single institutional, mostly retrospective. There's not a lot of attention to what's the quality of the surgery, what's the quality of the pathology specimen like we do with rectal cancer. A lot of these studies go over decades, so there are a lot of other changes in care, oncology care, perioperative care, imaging. There's a lot of technical issues with these operations that may lead to increased complication rates that are concerning, and there's still not great long-term data on these patients. Here's the original paper from 2009, and the picture on the upper right shows you, they're really essentially saying, take your principles from rectal cancer and apply them to colon cancer. So stay out of the mesocolon, stay in the embryologic planes. And you can see on the right, if you can see that picture, a Coker maneuver so that you can ligate the ICA right as it comes off the SMA. That's what they mean by central venous ligation, literally taking the right, the middle, or the left, or the IMA right as it comes off the named vessel. They published their series, which was about 25 years. A lot of these patients had advanced disease, stage 3 and extramural vascular invasion. And on this next slide, what I'm going to show you is first look at the median lymph nodes, 32. And then if you look at the complications, a little bit higher than I think a lot of us would like to see, whether you're talking about total or mortality or leak rates. And if you look at the orange table, you can see the local recurrence from the first years to the middle years to the last years was essentially half local recurrence. And they attributed their increase in cancer-specific survival from 82 to 89% because of the adoption of this technique. And so they say, yep, we think CME is appropriate, and here are the elements of CME, and this is what we're going to do. In Norway, they had actually published a study in Norway in 2000 looking at the lymph node sampling in colon cancer surgery, and it wasn't adequate in many centers. And so they saw this study out of Germany and said, well, maybe we should try this. So at Hospital A, going forward, we're going to do CMEs. At hospital B and C, we're going to do standard surgery. And they had about 84 patients versus 105 patients. Interesting, a third of them were done minimally invasively, which is pretty challenging. And what they found was decreased mortality in the CME group, more lymph nodes, but look at the lymph nodes there. You're talking about 15 versus 16, decreased local recurrence in half, and look at the improvements in overall survival and disease-free survival. But if you look closely at this, it's in the stage 1 and 2 patients. Why would CME improve survival in stage 1 and 2 patients? That doesn't really make sense. So not really sure what to do with that data. Here's a meta-analysis looking at CME for conventional surgery, looking at all the literature out there. Of care and evaluation. And again, they clump together the CME and the D3, and that's not really appropriate. They're not the same. So they actually stated definitive and sustainable conclusions from prospective studies are missing. A lot of the improvement in survival may be due to the adjuvant chemotherapy these patients are getting. So we need a good trial, and here's the good trial that's being done. The RELARC trial is being done in China right now, 17 hospitals, randomized controlled trial, basically looking to see 3-year disease-free survival. I literally checked every day to see if it got published yet. The abstract only has been available. There's a lot of attention to quality in this study. Surgeons get selected based on their experience. They've got to have done this number of this number of this, photos in the operating room pre and post dissection, video of the surgery, photos of the specimens, grading of the specimens. So a lot of attention to really seeing the quality of the actual surgery. Preliminary results, again, abstract only, longer operations, 26 versus 23 lymph nodes, and maybe some increased vascular injuries in the CME group. They're actually tracking every single vascular injury by vein, by artery. Overall, no big differences in perioperative complications, but when you really break it down, you can find some differences. I'm going to move on to the third area of conversation now, neoadjuvant therapy for these patients. We use it for rectal, esophageal, gastric, other GI cancers. Should we use it for colon? A lot of the patients that have these criteria, these locally advanced patients, we operate on them, we give them chemo, and despite that, 20 to 50% of them are going to fail within 3 years. So can we do something else? And I've listed the pros and cons of neoadjuvant therapy, which many of you are familiar with. Basically you want to downstage, shrink your tumor, increase your ability to get an R0 resection, maybe increase your ability to do it MIS. What's the bad? Well, if they don't respond, their tumor grows, it progresses, it spreads, it maybe obstructs or perforates. And another big issue is you may overtreat a lot of people. You give them upfront chemo and they were only stage 2 with no negative prognostic features, you've overtreated. So there was the Foxtrot trial, which basically, to put it simply, it took one group of patients and said, we're just going to do what we've always done, surgery, 24 weeks of chemo afterwards. And then the other group, they gave them 6 weeks of chemo up front. Some of them got immunotherapy also. I won't get into that. And then after the surgery, they got the remainder of the chemo, which was 18 weeks. About 1,000 patients over 8 years all throughout Europe. A lot of advanced cancers, T4s and lymph node positive, used the standard chemos that were available at that time, median follow-up of 3 years. It did not reach statistical significance for the primary outcome, which was a decrease in residual or recurrent disease. There was a 28% lower recurrence, but it did not reach statistical significance. Mortality changes did not reach statistical significance. There absolutely was decrease in tumor size, tumor grade, node positivity in 62% of patients. There were improvements in negative margins from 10 to 5%. And there were no increases in surgical complications. So if you look here, the very top line of the first table shows that they did not reach statistical significance at 2-year failure. But again, node positivity went down, T stage went down, margin R0s went up. And if you look over on the right side, the subgroup analysis, clearly the people that responded had better 5-year survival. They broke them down into quartiles, and the people that had the best responses had the best 5-year survival. So this was the first phase 3 trial for neoadjuvant for operable colon cancer. It's safe. The chemotoxicity is the same. The perioperative complications are the same, but it did not reach its primary goal of recurrent disease being decreased significantly. Probably need more follow-up. And about a quarter of the patients were overtreated based on final assessment. So they were staged with CT and they were overtreated. 4% went on to need emergency surgery. So that was a bit reassuring. It's a pretty small number. The other large trial is the Protégé 22, multi-center trial being done in 120 patients. Again, similar, 8 weeks neoadjuvant followed by 16 weeks of chemo after surgery versus your standard surgery and then chemo. Again, very good tumor regression, very good tumor downstaging. No difference in survival was seen. So it's safe, it's feasible, but it seemed underpowered to detect a survival advantage. And in their discussion, they said they didn't meet their goals. 33% of their patients were overtreated based on the preoperative imaging. Here's what's out there right now as far as neoadjuvant treatment for locally advanced colon cancer. In this meta-analysis, they looked at 1,200 patients, and again, seeing tumor regression, tumor downstaging, and some of the studies showing some improvement in disease-free survival, but not all of them. And here's what's out there. You can see I put in the box at the bottom the ongoing studies. What do we need answers to? You know, which chemo regimen, how long do we wait to go to the OR? What do we do as far as restaging before we go to the OR, et cetera, et cetera? There are, about 8 studies going on right now to help us answer this question. And here's one last meta-analysis that I looked at that I just highlighted because in this meta-analysis, looking at 2,000 neoadjuvant patients, they did see improvement in overall and disease-free survival, about a 25% improvement. The R0 resection rates only improved as a trend, and they felt that it mostly benefited the T4 patients. I'm going to move on to the last topic, which is how good are we with initial staging of these patients, these locally advanced patients? Why do we need good staging? Well, all the things I just talked about. If you want to offer them MIS or CME or neoadjuvant therapy, you got to be able to stage them. And if you really think about it, we took histology staging, handed it to our radiologist, and said, find me these things on CAT scan. They're not good at it. They will tell you they're not good at it. It's not good for detecting tumor depth, and it's not good for detecting lymph node positivity. So maybe MRI has a role, and I've got some studies to look at that. So first, how good is CT, for example, for detecting right colon cancer? This is from Cleveland Clinic, Florida, and from Brazil. They retrospectively looked at 150 patients over 5 years and said, can we find the patients that should get either Foxtrot or Protégé 22 criteria? Can we find these patients with CAT scan? And the answer is absolutely not. CT didn't even find 18% of the cancers, false negative for lymph nodes in a quarter. The T stage and end stage were overstaged 25% of the time, understaged half the time, very low sensitivity for extramural vascular invasion. And if they ask the radiologist, can you just find me any one criterion that would trigger neoadjuvant therapy or CME? And the answer was, they're accurate about 2/3 of the time. So no, according to this paper, CT is not sufficient for staging these patients. So is MRI any better? Here's a study looking at CT versus MRI to try and accurately identify these T3C patients, the ones with deeper invasion. And they basically had 2 radiologists blinded to each other, blinded to the patients. Each of the studies goes over specifically which MRI criteria they use for lymph node positivity and for T staging. If you can imagine, you can make it more stringent and then you'll be more sensitive, or you can make it more lax and then you'll be less specific, right? And so they vary a little bit in their outcomes. This is a busy slide, but basically what it says is between their 2 readers, they were moderate at best for accuracy in detecting T3C positive, T3 positive, node positive. If you ask them to read the same CT or MRI and did they agree, about 50% of the time or less for these criteria, whether it's CT or MRI. Motion artifact is a problem with the MRIs for colon. And if you took out the bad studies, the quote bad studies, their accuracy went up about 10%. But basically they found for trying to find these patients, their radiologists were moderate for all categories at best. How about just looking at sigmoid cancer? With MRI, here's 41 patients. Again, can we find the patients that meet criteria for either neoadjuvant therapy or recommendation for complete mesocolic excision? This study showed yes. So if you look at the first row here, can they detect T3, CD, or T4? Pretty damn accurate, pretty good sensitivity, pretty good specificity. Lymph nodes, the numbers drop off. Extramural vascular invasion, the numbers drop off. Small study, but a little bit of hope there. And so they said MRI may be better at discriminating malignant tissue from the muscularis propria. CT scan has a lot of problems differentiating between desmoplastic tissue and neoplastic tissue. The lymph nodes, you can get false positive lymph nodes. You know, if the lymph nodes are big because they're inflamed, you can get false negatives if they're small and they just have micromets in them. You get different cutoffs for the lymph nodes, which lead to different sensitivities and specificities. The whole concept of using diffusion-weighted imaging like we use for rectal cancer, it needs a lot of work. It's very dependent on the reader and the study. So a lot of work still to be done here, but perhaps MRI will help us. And here's a prospective study being done. That was done between CT and 3T MRI. It looked at 118 patients, again, trying to find these patients that were locally advanced versus early. And they, again, listed their criteria for what's a positive lymph node, a little bit different than the other groups. And what they found, again, CT failed to detect 16, so about 12% of the colon cancers. The sensitivity of MRI was about 30% higher. The specificity between CT and MRI was not statistically significant. For detecting lymph nodes or extramural vascular invasion, less than 50% for both. So they found the 3 Tesla MRIs were better than the 1.5 Tesla data that they had seen, and that there was more agreement between their radiographers with the 3 Tesla MRIs. So in conclusion, and I have 16 seconds left, so I did it. In conclusion, is MIS appropriate for locally advanced colon cancer? My interpretation of the literature, if you get through your learning curve with laparoscopic or robotic, I believe the answer is yes, and I favor robotic personally and based on the literature. What is the role of complete mesocolic excision? If you look at the studies, we went from 12 to 20 to 28 lymph nodes in a lot of our data. My interpretation of the data is you need more than 12, and I think the Pathology Society is looking at this right now. I shoot for, in our recent study we published, our average was 19 for our rights. I'm shooting for 15, 20 or higher, but I don't believe you have to do central venous ligation, central vascular ligation based on my interpretation of the literature. What's the role of neoadjuvant therapy? I think there's going to be a role. These tumors do shrink, they respond, the lymph nodes respond. We just need more patients and more time to show the survival benefits. And is CT sufficient? And you know, when all of you go to your tumor conferences, a lot of times in the tumor conferences, the radiologists speak like their word is the word of God. And I don't mean they're bad people. I'm just like, this is the answer. It is not the answer. CT is good, but it is not pathology, for example. So thank you very much for your time, and thanks for the invitation.
Thank you, Dr. Rosen. A lot of information and kind of jam-packed with some controversies and questions. I'll go ahead and open it up if anybody has any questions or comments on this topic. I'll go ahead and start. Where you seem to allude that CT is not great. So where do you see us going in terms of a 3T MRI for colon cancer staging, and what needs to be in place for us to really have reliable preoperative staging for that?
So I did not include in the talk, there was some other literature. For example, in last month's Disease of Colon Rectum, a group in China started to use different criteria on CT. So for example, visceral adipose tissue. And they were able to kind of come up with criteria to help define where there is serosa, for example, and where there isn't on the left and the right colon. And when they used their new criteria, so they basically said what I said before, which is we're not going to use histologic criteria. We're going to create new radiographic criteria and stage people based on that. And their numbers were quite impressive. And then I do think if we can have more studies with the 3 Tesla MRIs, that will decrease a lot of the motional artifact. I think it will be shown to be beneficial. And then there's the cost and the time that we're going to deal with there.
And then I have a question about the CME. So if you are a reasonably trained surgeon in MIS surgery, and you have the option in a locally advanced, say, right colon cancer, what would be, say, the advantages of perhaps doing it MIS versus doing it open with the central mesocolic excision?
Yeah. Thank you. And I think that's a great question. One of the other things I didn't point out is in many of the studies of CME, they did look at what was the rate of positivity of that D3 node dissection if everything else was negative. And the answer was 2 to 3%. So most of these patients, you're going to be doing these dissections. So 97 to 98% of these patients, at least, I don't believe are going to benefit from CME. So I that's where I fall based on my review is, so when I do a right, I go to the patient's right side of the SMV, and that's where I stop. These dissections would go to the left side of the SMV and even higher.
Great, thank you. Anybody have any comments or questions about that topic? Okay, so we'll move on to our next speaker. Thank you. Our next speaker is Dr. Sunil Geevarghese. He's a native of Tennessee. He graduated from Vanderbilt University School of Medicine and stayed on for his general surgery residency, then followed by transplant surgery fellowship at UCLA. He recently received the inaugural 2019 ASTS Pipeline Award, which recognizes dedication to the transplant surgical experience of medical students and residents through recruitment, research, and mentorship. Welcome. He's also the co-moderator for this session.
Thank you very much, Virginia. Thanks also for the invitation. Really appreciate the opportunity to share a little bit of my passion, and it's perfect that it follows your talk because we're going to stay on colorectal cancer for a few more moments. No disclosures. Now, we're going to actually spend a little bit less time primarily because I want to dig into something a bit controversial at the end of the case. So a little less time on what we do commonly for colorectal cancer. But we're going to spend a bit of the time on resectable synchronous metastases. That is, those colon cancers that present with the primary and the metastatic lesion in the liver at the same setting. And then what I think is the true controversy here is how we handle unresectable liver metastases. Now, this is the big picture. Some of this has already been stated, but I'll skim to the point here that we are seeing more colon cancer in younger individuals, and it's falling among older adults. And I think it's important to recognize that, and I hope that it might spark more interest in you in thinking outside the box of resection later on. The bulk of this part of the demographics were taken from a recent ASCO guideline that was just issued by my friend, Dr. Kathy Eng and colleagues. Now, metastatic colorectal cancer is much more common than we might think. Up to a third to a half of patients will have metastases either synchronously or later on in their care. The overall survival is relatively low at 5 years at 15%, and untreated 6 to 9 months median survival, with systemic therapy perhaps twice that. Now, this is information taken from one of my former residents who's a hepatobiliary surgeon at the University of Virginia, Vic Safedin. Now, here's, I think, the bottom line is when in doubt, make the decision together with your collaborators in medical oncology, radiology, surgery, as well as I think a new field will open up at the end of my talk. So tumor board in whatever form or fashion, be it organ specific or otherwise, I think is key. But let's jump into how we face the synchronous lesion. Now, we know that with systemic therapy alone, you have this survival 5 to 10%. And then if it's resected, you have higher survival up to 60% at 5 years. But 30-day mortalities is pretty high, around 30%. And for those that are resectable, of those that present, 20% are resectable up front. And then about 50% get neoadjuvant therapy and then may be deemed resectable. So the question comes to mind, what do you do? Do you do neoadjuvant therapy first, or do you resect your primary and maybe even at the same time deal with your liver, followed by adjuvant therapy? So this is a big question, and I think you'll find probably in practice more variety than you see in papers. So I'm going to tell you what the papers tell us, but I would be really interested to see what folks are doing in practice. Now, the theory behind resection first is that you eliminate or mitigate tumor shedding at the time of your resection. It avoids the emergent surgical procedures for obstruction and hemorrhage potentially that can occur during systemic therapy. And there are, of course, complications to the liver with systemic therapy, particularly if it's prolonged over a year. You have chemo-associated steatohepatitis, sinusoidal obstruction syndrome, and then non-cirrhotic portal hypertension that can arise. Now, for those who prefer systemic therapy first, then you can have surgical complications when you delay, surgical complications will delay systemic therapy initiation, and that's an issue. And of course, if you progress on therapy, then you potentially can limit the need for a resection that may not actually help. So this is the big picture on how to handle colorectal cancer in the setting of synchronous metastases. For the purposes of demonstration, I'll just mention again at the very center is multidisciplinary discussions. Whether you have resectable or unresectable, the key thing is it symptomatic? And based on the symptoms, it takes you down the line to stenting or diversion, and then otherwise an iterative plan between chemo assessment and resection potentially reconsidered. This is an important statement. Again, I wonder if this is what people actually see in their communities. Upfront resection of an asymptomatic primary tumor in patients with synchronous metastases delays the initiation of systemic therapy without proven benefit. And this is actually a paper written by surgeons, so just to be clear. Now, I'm a liver surgeon, and of course, this is a big part of my practice as a hepatobiliary surgeon. And so it would stand to reason I spend the next 30 minutes talking about liver resection, but it's actually only one slide, because I think what's really interesting is the everything else outside of resection. Not to minimize the cool factor for those of you in trainees, hepatobiliary surgery is very cool. But I always love to show that first picture at the very top, and that's Prometheus. Many of us know the story of Prometheus, how he was chained to Mount Caucasus because of defying Zeus and giving the gift of fire to mankind. Well, he was perpetually tortured because his liver was eaten while he was alive, and because it regenerated, the vulture or eagle would come back the next day and continue to take with torture his liver. Well, in some ways, in hepatobiliary surgery, there is a multi-operational approach where some have argued that we do a multi-stage resection or a two-stage hepatectomy where you remove part of the liver tumor, then you treat, then you remove the other part of the liver tumor. That added, even with the additional complexity of something called ALPS, which is more often talked about than done in the United States, which is associating liver partition and portal vein ligation. That procedure is quite complicated with up to 30% morbidity, but sounds cool in that you take an individual who has borderline resectable disease, you split the liver and divide the portal vein on the side that's coming out, and within a week, you see really remarkable hypertrophy, and then you do the rest of the operation, which is more straightforward, essentially taking the arterial inflow and the hepatic venous outflow, and then you're done. And so you can really push the limit on how much you can resect. But how much of the future liver remnant is enough? Well, Quinault taught us in the 1950s that the liver can be taken apart like Legos. Wouldn't that be nice? But that's not actually the way it happens. And Jim and many others who do hepatobiliary surgery know that there are no planes between the segments of the liver. And so we're often following our own understanding and using intraoperative ultrasound to guide us. And in the end, we might feel that we are going to resect enough liver and leave the patient with adequate liver, but what is adequate is still an open question. Maybe if you have a perfect liver, 25% of your future liver remnant volume is adequate. Most often, however, patients are heavily treated pre-op, develop chemo-associated steatohepatitis, and then suddenly, as a liver surgeon, I'm faced with the liver that actually overall liver tumor, I can resect that, but the future liver remnant is insufficient. So how do we start with unresectable disease and move it to resectable disease? This is from ASCO guidelines, very detailed approach where bevacizumab plus either doublet or triplet therapy, FOLFOX or FOLFOXIRI, is first-line management for the initially unresectable, microsatellite stable, proficient mismatch repair metastatic colorectal cancer, the goals of which are to prolong survival, stop progression, and allow subsequent resection. The good news is, if done right, after a 2 to 3 month period of time, disease would be resectable. It's quite actually effective, particularly now in combination with pembrolizumab as first-line therapy, that you can actually see remarkable decreases in size of the tumor. But we do that over 2 to 3 months time, neoadjuvant therapy, and then reassess afterwards. Now, that reassessment process can often identify individuals that have moved into the resectable cohort, and often because of Bev and other toxicities, bevacizumab that is, can require us to wait 6 to 8 weeks until after the adjuvant therapy is completed, and then we can consider resection. But I like to insert this little pause for those of us who are aggressive hepatobiliary surgeons. This is a term I coined called, essentially taken after caveat emptor, in this case, caveat chirurgus, which means let the surgeon beware. And many of you may know the story behind Pyrrhus. That is his bust. Pyrrhus was a general who, in dealing with the Roman soldiers, deployed the bulk of his troops and won the battle, but essentially lost the war, or nearly lost the war, because he had lost all of his troops and his generals in the process of that battle. So the Pyrrhic victory in this setting is essentially doing a heroic liver operation and finding your patient saddled with such morbidity, mortality, that the value is completely obliterated. So there's the story, as I mentioned a moment ago. So how do you face unresectable disease? So that was a pause before we move into this. This is the definitively unresectable disease part of our discussion. Survival often is limited to, or is linked to, control of the distant disease. If your liver disease is unresectable and the primary is resectable, still start with systemic therapy. This is the official recommendation. Less than 20% of metastatic colorectal cancers require resection. The JCOG 1007 randomized controlled trial actually demonstrated a similar median survival between those who are treated with systemic therapy versus primary tumor and resection and systemic therapy. Thus, consider avoiding that surgical resection of the primary if it's not obstructing or bleeding. Now, there are a number of non-surgical options. Taking down the left side of this, RF ablation, microwave ablation can lead to very reasonable results, 5-year survival, in some studies up to 40%. It is associated with 30-day morbidity as high as 15%. Then there's arterially derived or arterially based therapies, chemoembolization and Y90. Most of this is born out of the hepatocellular carcinoma world, where those tumors are primarily arterially driven, metastatic colorectal not being the case. Its response perhaps much less, and you see 4 to 7%. So not something we in general would require or recommend up front. Now, to the controversy. What about transplantation? I'm a transplant surgeon. We're newcomers to this idea. And from this nice review article by Kareem Halazan at NYU, he has stated several reasons why we ought to consider liver transplantation for colorectal cancer. Now, more than ever, we have seen improvements in transplant oncology, or that is transplant as a part of an oncologic practice, primarily born out of our work over the last several decades with hepatocellular carcinoma. Different tumor type, I admit, but nevertheless, it demonstrates improvements, refinement in staging, improved understanding of tumor biology, improved efficacy with local regional therapy, optimization of patient selection, and a 5-year survival in transplantation for HCC that's upwards of 75%, which I think the pancreatic surgeons would dream about achieving. Now, why don't we just consider removing the entire liver and therefore not struggle with the Pyrrhic victory idea I just talked about? Well, there is an increasing disease prevalence now in younger individuals. Over 70% of these young individuals with colon cancer are presenting with unresectable disease, which is horrifying, of course. It should be for those of you who are with me. Prolonged systemic therapy can, as I mentioned earlier, lead to liver dysfunction. So some of the very earliest experience is not new. This goes back many years to around the 1990s, where Mulbecker and colleagues transplanted 55 patients with metastatic colorectal cancer. 1-year survival by transplant grounds, 62% is pretty poor. 5-year survival of 18%. Immunosuppression, however, was very different in the 1990s. And perioperative morbidity, very different as well. So I would argue this was just the preliminary experience, but not what we should take as what can be accomplished in the modern era. Now, 2 major studies, the SICA trial in 2013 and the Compagnon trial in 2017, both had more favorable, obviously more modern and more favorable results. A median 5-year survival in the SICA study up to 60%, with 1-year disease-free survival as much as 35%. It did identify unfavorable pathologic features, which makes sense in some ways. If you have a long duration of time between diagnosis of the primary and the metastasis, as the treatment of choice for unresectable metastatic colorectal disease. Well, most certainly can be considered a chronic disease. Many of our patients with unresectable disease can be maintained on systemic therapy for years sometimes. We now have a better understanding of the tumor biology, I would argue, but there is a concern about utility and scarcity of the organ, the liver transplant organ. But perhaps that is going to change too. Because for those who are in transplant know that we're now on the forefront of seeing mechanical perfusion, normothermic regional perfusion, and that may completely change the way we not only approach timing of transplant, but the kind of organs we're able to consider. Many of you in training know or have heard the term marginal organs or extended criteria organs. Well, we might actually be facing a day where all those organs are usable. We simply put them on the pump, we demonstrate their function and move on. Well, if suddenly we're able to increase our pool of organs, maybe it makes sense to consider innovative approaches toward colon cancer care like transplantation. So I leave you with this idea, and I have 3 minutes left. So yay, that's great. And that is transplantation as part of the armamentarium in oncology. Transplant oncology, a term I think most certainly that can be used for hepatocellular carcinoma and perhaps cholangio as well as neuroendocrine, but primarily hepatocellular carcinoma. And now we can see this extend as one of the many options we consider: systemic therapy, resection, local regional therapy, and now liver transplantation. It's a great honor to speak and to borrow a few minutes of your afternoon. Thank you, Virginia, John, and President Richmond, and the whole program committee for the opportunity.
Thank you so much, Daniil. That was a kind of wonderful walk through metastatic disease. I'll leave it open for anyone in the audience who wants to kind of have a question or comment.
Sunil, great talk. Back, I'd say 15, 20 years ago, some of the issues we worried about were disease-free interval, CEA levels, size of tumor segments, and that type of thing. You didn't mention any of that when considering transplant. Is that relevant, or if you can get it all out, you would consider it?
I think that's excellent. Thank you for your comment. I would say ultimately we're learning what are the favorable features. We identified some unfavorable features, of course, in that early SICA study in terms of CEA, and the tumor size, but the number of lesions was not part of that. And so I think the response to therapy as the primary reflection of tumor biology is really important. All of these unresectable patients, at least in the 2017 study, the Compagnon study, had approached to systemic therapy. So we need to incorporate other variables other than a static single lesion measurement, and the response to therapy might be that one. In the world of hepatocellular carcinoma, we very routinely use response to therapy as an indication. In fact, we prioritize organ availability for that diagnosis based on whether they have responded to systemic therapy. So that's definitely established, but I think you're exactly right. We need to look beyond just static numbers and size and resectability and add response to therapy.
Yeah, I have a question. Is there any role for using the techniques and experience from transplant, but without the actual transplant? So like back table dissections, is that done anywhere? Is there any research in that? Is there any future in that?
I think the closer we get to applying those skills would be ALPS procedures. I think I'd be hard pressed to imagine anyone who's doing ex vivo resections, where you take out the whole liver and you do resection on the back table. Most certainly we've done this for hepatocellular carcinoma. I think more commonly now with the powerful immune therapy modulators, we're seeing really impressive response to treatment. So historically we use local regional therapy and other approaches to control tumor size. But now, in addition to systemic therapy, I think truly radical approaches like removing the entire liver and putting it back in there likely is not going to be where we go forward. I personally would like to see how ALPS can be spread from the many centers that do it well to most centers, but the morbidity is so high that I think these advanced resectional approaches are perhaps going to be limited at some point, because we are going to take patients who are unresectable and then so heavily treat them, but by the time they get referred, their ability to tolerate these massive resections is going to be limited. And that may be an argument why we should be considering transplantation. You give them the therapy they need and not worry about the liver because it comes out. So, I mean, it seems cavalier, but I think it obviously is more complicated than that.
Hi, Sunil. Another question. In regard, any thoughts on hepatic artery infusion pump as a kind of a bridge to transplant, just to prove that they're not going to develop any distant metastatic disease besides liver only?
Thank you very much for mentioning that point. And I deliberately left that out, mostly because I don't know that it's been established in a pathway to liver transplantation. And I know Dr. Kemany's work, and basically anybody who's ever trained at Memorial believes so passionately about the pump. One of my former trainees has returned to us after spending 2 years with her, and now he's putting in a pump too. So I think you're exactly right that I need to insert that in my transplant oncology element, but I don't know that we have as many individuals that are doing that, so it perhaps not as common, but you're right to mention that that is definitely part of the armamentarium. As a segue to transplant, however, I think it brings up a really important point. If this is liver driven or liver only disease that we're going to be transplanting, can we intensify treatment using the pump and maybe put that up front in the pathway prior to transplantation? It's a really good point. I will just say again, as a transplanter, one of the dynamics of having a catheter parked in the hepatic artery is I've got to use the hepatic artery. And it's not uncommon to find the catheters moved and changed positions and led to thrombosis. So I think at first blush, I'd probably have some pause. But you're exactly right. This is not prime time yet. That's the bottom line answer to that question, transplantation, that is. So whatever has worked, and of course, Dr. Kemeny has shown it's worked and others, her disciples have. So I would argue that whatever you need to do to prove that this is truly unresectable, you do what is appropriate in your center. But thank you for mentioning that. I do need to include that. All right, it's my pleasure to introduce Dr. McGuire, Dr. Candace McGuire, if you'll come up, please. She's a surgical oncologist at Virginia Commonwealth University. She obtained her medical degree at Eastern Virginia Medical School and completed her residency and research fellowship at Thomas Jefferson in Philadelphia. She also completed a fellowship in breast surgical oncology at the Moffitt Cancer Center and Research Institute. Her clinical interests include breast cancer, general surgical oncology, and breast cancer research.
All right. Well, thank you all for your time and attention today. I'm going to try to motor through two of the most controversial aspects of breast cancer surgery today. There were tons of things I could have chosen in breast cancer, but I wanted to keep it surgical for our surgical audience. So when it boils down to what's controversial in breast cancer, really, it's all about the axilla. It's really about staying the heck out of the axilla or minimizing what you do in the axilla to minimize morbidity. So in general, sentinel lymph node biopsy has become the standard of care. We all know that. We answered it on our boards for nodal staging and early stage clinically node-negative breast cancer. However, there are new opportunities that have arisen to limit the amount of axillary surgery done after undergoing neoadjuvant chemotherapy and also potentially eliminating axillary surgery in some patients above the age of 70. So today we'll talk about method and timing of nodal staging, significance of the axillary response in neoadjuvant chemotherapy, something called targeted axillary dissection, although it does have a few other names, and the choosing wisely guidelines and how they relate to limiting axillary surgery in women above the age of 70. So just to do a quick rehash of sentinel lymph node biopsy, because I'm sure most of the folks in this audience are not breast surgeons. If you remember from your training or what you do every day, when you're looking at somebody who's got breast cancer and want to stage their axilla, in most cases, you're going to inject 1 or 2 dyes in the breast. You're going to allow them to transit to the axillary lymph nodes that drain the breast first and evaluate those rather than removing all of the lymph nodes in a formal axillary lymph node dissection. This has been well studied. These are trials that we all should know and should have studied for our boards. B32 being one of the largest ones, showing a false negative rate of 10%, accuracy of 97%, and identification rate of 97%. So pretty darn high. And here you can see that in that trial, overall survival and disease-free survival were equivalent between those patients who underwent sentinel lymph node biopsy versus full axillary lymph node dissection. So why do we do this? We do this because patients who have axillary lymph node dissections tend to develop lymphedema. So it happens in about 30% of patients who undergo traditional levels 1 and 2 axillary lymph node dissection, and even happens in the best case scenarios in about 2 to 5% of patients who have sentinel lymph node biopsy, or some people will call it sentinel lymph node dissection. So sentinel lymph node biopsy, perfect board's answer, easy answer for those patients who are stages 1 and 2, early stage. But what do we do in those patients who present with locally advanced breast cancer? So one of the options in somebody who is going to undergo neoadjuvant chemotherapy for locally advanced breast cancer is to look at the sentinel lymph node biopsy before neoadjuvant chemotherapy. Several pros to that. It may help you determine what kind of chemo you're giving and what radiation the patient might need. Certainly, this is something we're all very experienced in and very comfortable with, and the axillary recurrence rates are low. However, you are guaranteeing that patient is going to get 2 operations. You may delay the commencement of systemic therapy, which no matter what disease process you're talking about is the life-saving intervention for patients with locally advanced disease. And you lose the ability to know how that lymph node would have responded to the systemic therapy. So what most centers are doing at this point is doing axillary ultrasound and core needle biopsy of anything that looks suspicious. Axillary ultrasound in and of itself is not fabulous. We look at really 3 things. We look at height to length ratio, cortical thickness, and effacement of the hypoechoic hilum. And what you'll see is that, when you look at AOCs, they're good, but they're not great. So axillary ultrasound alone is not fabulous, but when you combine it with biopsy of anything that looks suspicious on ultrasound, you're going to get a fairly high sensitivity and a very high specificity for nodal metastasis. So let's look at that significance of nodal response and why it's so important and why we may want to change the way we're doing things. So this is a study from von Minkwitz et al. And this looked at nodal status post-chemotherapy and how strong of a predictor of outcome it was. And you can look at this is stratified by post-chemo nodal status. And whether you're looking at disease-free or overall survival, nodal status after neoadjuvant chemotherapy is a strong predictor of overall survival and disease-free survival. When you look at the Neo-Tango data, 6% of patients had residual disease in their axilla, regardless of pathologic complete response in the breast. And even in a pathologic complete response, these patients still stratified by nodal status in the axilla, both from a disease-free and overall survival aspect. So axillary conversion is actually the most strong predictor of overall survival in patients undergoing neoadjuvant chemotherapy. The size of that metastasis is not important. Even if it is a small metastasis, it is still prognostic of a worse outcome. And the evidence of nodal response associated with improved disease-free survival is very clear. So if we're going to look at a patient after neoadjuvant chemotherapy, how are we going to evaluate those nodes? How are we going to ensure that it is accurate? So the pros of doing that are that we have large series that suggest comparable accuracy in the clinically node negative patients at presentation. So these are patients who have locally advanced disease in the breast, but nothing clinically in the axilla. We don't delay chemotherapy. It's a single procedure, and the information regarding nodal response is, as we saw, very important. However, there's limited data regarding axillary recurrence rates in this population, and there's a highly variable false negative rate if node positive before chemotherapy, up to 30% in some series. So when we look at those node negative patients, we've got several studies that show, like I said, comparable identification rates and false negative rates to patients who are not undergoing neoadjuvant chemotherapy or patients who had their sentinel lymph node biopsy done prior to neoadjuvant chemotherapy in the node negative population. However, when we look at sentinel lymph node biopsy after neoadjuvant chemotherapy for node positive patients, what we'll actually see is that the false negative rate is greater than 10% in most of these studies, which is really what most people will consider an acceptable cutoff. So we look here at ACOSOG Z1071, Sentina, the FNAC trial, and the Swedish trial, all of which showed pretty poor node false negative rates in overall cohorts. However, there are things that can be done to reduce this false negative rate. Now, in some of these studies, these were pre-specified endpoints, and other ones, these were unpre-specified subset analyses. Dual agent tracing. So using both a radioactive dye and some sort of a colored dye, whether that's a blue dye or indocyanate green, or some of the newer tracers, that will reduce the false negative rate. Retrieving greater than or equal to 3 lymph nodes reduces your false negative rate to under 10% in every study in which that was studied. However, even using dual tracer, we're still looking at a false negative rate of 6 to 13%, which is pretty wide variability. And you cannot guarantee the number of sentinel nodes you get out. The nodes are the nodes. If they light up, they're sentinel nodes. If they don't, they don't. And you cannot just start picking lymph nodes out and saying they're sentinel nodes to get your 3. So that's when people started to look at, what about that initially positive node, the one that we biopsied and hopefully somebody clipped prior to chemotherapy. If we identify that lymph node and identify it and resect it during the sentinel lymph node dissection, what is the false negative rate there? What is the accuracy rate? And can we use that to have a more successful sentinel lymph node dissection after a neoadjuvant chemotherapy? And so that is really what people have turned to in some of these studies. The challenge, really that we want to do is to decrease the extent of surgery and decrease morbidity. So like I said, why are we localizing that clip lymph node? Wouldn't it just come out as a sentinel node anyways? Well, in a lot of studies, it doesn't. So 24% of patients who were part of ACOSOG Z1071, which was a single arm trial, they had a sentinel lymph node biopsy and then went on to have an axillary lymph node dissection. 24% of them, the clipped lymph node was in the axillary lymph node dissection specimen, not a sentinel node. And MD Anderson and University of Pittsburgh both showed a 9 to 23% chance that your clipped lymph node would not present as a sentinel lymph node biopsy after neoadjuvant chemotherapy. So really the best way to guarantee that you're going to get that node out is to stick something in it so that you can find it at the time of surgery and not leave it to chance. So one of the more draconian ways of doing it is sticking a wire in somebody's axilla during the day of surgery. Nobody likes it. The radiologists don't like it. The patients don't like it. Surgeons don't mind it once they're done listening to the patient complain about it in pre-op. It works, but it's not the best method. So there are a lot of non-wire localization devices that we use. The gold standard for a long time was radioactive seeds, I-125 seeds, which are typically used for prostate cancer. But there are also some non-radioactive options, all of which work just fine for this indication. And so that's what they did at University of Pittsburgh. They used radioactive seeds there, and they called, rather than calling it a targeted axillary dissection, they called it a directed sentinel lymph node biopsy. And they performed this in 120 patients. Their accuracy was 98%, and their false negative rate was 6% when the clipped lymph node was identified and resected as part of their sentinel lymph node biopsy. Interestingly, they also demonstrated that recurrence was especially low in those patients who underwent sentinel lymph node biopsy alone, and that lymphedema rates were 5% in those who had the directed sentinel lymph node biopsy versus those who went on to have a full axillary dissection, which was about 20%. This is a really hard to read slide. I apologize, but it's really interesting information. MD Anderson did a very similar study. They call it a targeted axillary dissection. It is what it is. It rose by any other name. But what they found was that when they were looking at their sentinel lymph node biopsy with dyes alone, again, their false negative rate was higher than 10%. When they identified that clipped lymph node as part of their sentinel lymph node biopsy, their false negative rate was 2%. So that's pretty incredible change. And this was also redemonstrated at University of North Carolina using another non-radioactive localization device. They had a 5.1% false negative rate, and they found that accuracy was best if that localizer was placed prior to neoadjuvant chemotherapy. So really what we've seen is that this targeted axillary lymph node dissection improves accuracy in node-positive patients prior to neoadjuvant chemotherapy. False negative rate can be as low as 2%. And that TAD alone versus doing TAD plus the dye biopsy in an unplanned subset analysis was actually equivalent in accuracy and false negative rate. So I would love to say that that's standard of care. I've heard from a lot of folks around the country that this is not what they are doing currently, that they're waiting for long-term data and recurrence data to see if this is something they're going to be using. So for those who are in training, if you are a general surgery trainee, don't mention this on your boards. If you're a surgical oncology trainee, mention it on your boards. So now to move on to something that I would think is actually just as controversial, if not a little bit more, and that's limiting axillary surgery in patients above the age of 70. So some of you may be aware of the Choosing Wisely guidelines that are put out by the American Board of Internal Medicine, along with many subspecialty societies. And when you look at the Society of Surgical Oncology's Choosing Wisely guidelines, number one is don't routinely use sentinel lymph node biopsy in clinically node negative patients who are above the age of 70 with early stage hormone receptor positive, HER2 negative invasive breast cancer. I'm doing a quick scan, not seeing a whole lot of breast surgeons in the audience, but I would guess that if I asked how many people were doing this, it would be very few, despite the fact that it is number one on this nationally recognized Choosing Wisely guideline. So where did this recommendation come from? It seems to have just like snuck into the surgical literature. And really what it is, again, is sort of an unplanned subset analysis of a big clinical trial. So CALGB 9343 was actually a trial that was designed to assess the efficacy of radiation therapy after breast conserving surgery in women above the age of 70. In fact, it was above the age of 65. So they randomized patients to getting tamoxifen alone versus tamoxifen plus radiation, whole breast radiation therapy after a lumpectomy, to assess for local recurrence and overall survival. And that was their primary endpoint. But what they realized that in their cohort, if you look down here at the very bottom, is that regardless of whether they got radiation or they did not, only 38% of the patients in this cohort had any sort of an axillary assessment. So the surgical axillary assessment, so sentinel lymph node biopsy or axillary dissection, fewer than 40% of these patients were getting evaluated. And so they went back and sort of looked at how that affected overall survival and local recurrence. And they found that even in the patients who had not had an axillary assessment, while local regional recurrence was higher after a patient avoided radiation therapy, their overall survival was exactly the same. And so this led to the conclusion that axillary surgery in clinically node negative patients who have early stage breast cancer and are above the age of 70 or 65 does not change overall survival and should be omitted in appropriate patients. So lots of people will say, well, with the medical oncologist, the radiation oncologist, they need to know, they've got to know what's going on so that they can design adjuvant therapy adequately. And so what do we mean about bad ER positive cancers. So we're going to dig a little bit deep into the genomics of breast cancer. And so within the ER positive, PR positive population, we have two different subtypes. A lot of this was done at University of North Carolina. Chuck Peru developed the PAM50, which defined luminal A versus luminal B subtypes in ER positive cancer. But in general, without getting into deep genomics, luminal A's are the good breast cancers. So these are the cancers that are strongly driven by estrogen, progesterone, have a low Ki67, which is a proliferation index, typically lower grade, better prognosis, patients who are very appropriate for endocrine therapy only. Luminal B patients, although they may have some ER and PR positivity, will have lower positivity. They will have higher proliferation indices, higher grades, poorer prognosis, and may be better served by adjuvant chemotherapy. So how do we determine A versus B without running some very expensive tests that until recently was only in a lab? So we typically use a genomic assay that is commercially available. The one that is more commonly used is this 21 gene genomic assay, which takes the genes of the tumor and looks at genomic expression of 16 different genes versus 5 different reference genes and comes up with a recurrence score. If that recurrence score is high, you benefit from adjuvant chemotherapy. If your recurrence score is low, you do not benefit and you should have endocrine therapy alone. Prior to the RxPonder trial that came out in 2021 now, the belief was that all node positive patients would benefit from adjuvant chemotherapy, and they should be given that regardless of their receptor status or their risk score. So the RxPonder trial set out to disprove that notion. And so this was a cohort of patients who had 1 to 3 positive nodes after surgery. They were both pre and postmenopausal. That endpoint, that was actually described as above and below the age of 50, which is a decent surrogate. It was stratified by their recurrence score on that 21 gene assay. And what you can see here is that for the postmenopausal patients, which would include all of our patients above the age of 70, let's hope, regardless of what their recurrence, regardless of whether they had positive nodes or not, if they had a low recurrence score, they derived no benefit from chemotherapy and could avoid chemotherapy. It was different in premenopausal patients. We won't get into that. But basically, the nodes didn't matter. Biology trumped anatomy in breast cancer, just like it does in every other cancer that I'm aware of. So we looked at this at VCU. This is unpublished data. So, I'm telling you, but I'm actually going to have to kill you guys after you leave today. I apologize. But so we looked at almost 400 patients and we looked at who had, and these were patients who were above the age of 70 at diagnosis. 310 patients underwent standard sentinel lymph node biopsy at the time of their breast conserving surgery. 73% did not undergo axillary staging. And then we looked at their luminal status. Most of them were done by that 21 gene assay, which is commercially called Oncotype. Some of them we use something called IHC4 because we did not have the Oncotype available. 286 of our patients were described as luminal A, 97 were luminal B, and we compared disease-free survival and overall survival by sentinel lymph node biopsy and luminal status. And you can see on this Kaplan-Meier curve that these are our luminal A's and luminal B's looking at disease-free survival. And sentinel lymph node biopsy did on a Kaplan-Meier curve univariate analysis look like it was affecting disease-free survival. And in some patients in our luminal A's, perhaps affecting overall survival. So we got real nervous. But then when we looked on multivariate analysis, what you can see here is that sentinel lymph node biopsy, and I forgot to highlight luminal status, but sentinel lymph node biopsy was not predictive of overall survival, and it wasn't predictive of disease-free survival either. I just left that slide out for time. But luminal status, age of diagnosis, and number of comorbidities were the only things that were predictive of overall survival. When we looked at disease-free survival, it was luminal status and age of diagnosis. And so again, biology and other patient factors trump anatomy every day of the week and twice on Sunday. So in summary, targeted axillary dissection is feasible and non-inferior to traditional sentinel lymph node biopsy for patients undergoing neoadjuvant chemotherapy for node-positive breast cancer. We don't need to do a full axillary lymph node dissection. We've got great ways to assess that axilla. And omission of sentinel lymph node biopsy in patients above or equal to the age of 70 is safe and does not correlate with prognosis as much as tumor factors and comorbidities. So long story short, we're trying to save these nodes. We're trying to prevent lymphedema, especially in our older population where they're not going to deal with it particularly well. And I would really like to thank you all for your time and attention and for being asked to speak today.
Thank you so much. Welcome any questions or comments from the audience. In the meantime, I was curious how you get your radiology colleagues and everybody involved in the multidisciplinary care of these breast cancer patients to adopt some of these kind of newer strategies.
So at our institution, we pretty much do all of our breast cancer care in a multidisciplinary fashion. We review every new breast cancer patient at our tumor boards, which sometimes results in a 44 patient tumor board, which we've got coming up this week. But that allows everybody to get on board with treatment plans, new technologies, and they're all seen in a multidisciplinary fashion for their first visit. So so that if we determine that a patient would benefit from something like a targeted axillary dissection, at that point, we've got them, we can get them to our radiologist to get a clip in. And I think when you lay out that data for people, they understand the importance of it and they're very happy to participate.
For the neoadjuvant patients that you would bring to for the targeted axillary lymph node dissection, for those that have false negative frozen sections in the operating room, what do you do with the axilla on final pathology? Go back, radiate, both?
So that's why a lot of times I don't send a false negative in the operating or send a frozen section in the operating room, because you know, you have this high five moment and then you gotta, I would go back another day and do it. And a lot of times, you know, another cool new thing we're doing is the lympho procedure, lymphovascular anastomosis. And so if that's the case, I may plan to not send a frozen section and then return to the operating room with my plastic surgeons to do that if I do need to do an axe dissection. So yeah, I think if you've got a false negative, I mean, the answer is the answer, regardless, you go back.
Hey, I have two questions, Rachel, from Vanderbilt. I'm one of the breast surgeons there. First of all, when do you put the localizing clip in for your TADs? Do you do it before they initiate chemotherapy, during, or maybe towards the end?
So the best way to do it in more than one study is to actually put your localizing clip in prior to neoadjuvant chemotherapy, because some of the clips that are placed, the non-localizing clips, like you know, some of the Hydromark clips that have a gel base to them can get extruded from the lymph node during neoadjuvant chemotherapy. So if you have a technology that you can place prior to neoadjuvant chemotherapy, your identification rate will be higher. Some of those technologies, such as a wire, is not something you can leave in somebody for several months. And some of them interfere with MRI. So, you know, you really have to look at the technology you have and see if you can do it. But even if you can't, your identification rate will be fairly high.
Gotcha. And second follow-up question, I've been interested in definitely the lympha techniques that we can partner with our plastic surgeons in, but more and most are hearing buzz about SLIMFA that, you know, the surgeon themselves can do, which would negate the need to maybe like not send a frozen and go back. And I mean, I practice that way too, because, you know, I want a plastic surgeon to be there right now because I'm not trained. But do you know of any, you know, scuttlebutt on how to get training for SLIMFA?
No, I haven't actually seen any, you know, courses popping up or
Me
anything.
neither.
I mean, I know as part of the ARM trial, you know, they talked about dissecting out the afferent and efferent lymphatics and just tying them back together with a 3-vicryl, which was what I was doing before the lympho procedure. And I guess we'll kind of have to see in that study whether formal lympha versus SLIMFA.
And began work in finding pragmatic ways to overcome the many barriers to integrating palliative medicine into the care of seriously ill and injured surgical patients, as well as defining and elucidating spiritual suffering, grief, loss, and coping in caregivers. He's the co-director of Wake Forest's fourth-year medical student clinical clerkship in geriatrics and palliative care, and the deputy director of the third-year clerkship in surgery. He loves to teach ethics, and look forward to your discussion today.
Thank you. Thank you so much, Sunil and Virginia. So we've got a couple of quiz questions. If you want to use your smartphone, you can text my name without any spaces and without the last E and 271 to 22333 once, and that will let you get into the poll everywhere. And then when a question comes up, all you have to do is put A, B, C, D, or E and hit send. So these are my learning objectives. It's going to be a little bit different talk, I think, than the last three. We're going to look at the emotional states of patients facing life-threatening surgical illnesses and how that affects their decision-making. Explain how patient autonomy relates to freedom, control, values, goals, wants, and wishes. And then describe what I call patient-surgeon crosstalk, which happens pretty frequently in emergency high-risk cases, but specifically to this talk in advanced malignancies and how you might overcome it. I don't have any conflicts of interest to report. So the first question is, when do you get palliative care involved? Or when do you start performing primary surgical palliative care with your patients? There's a couple of commonly held fallacies by surgeons. One is that palliative care and surgery are mutually exclusive. Palliative care is the same as giving up when all else has failed. Palliative care equates to end-of-life care. But unfortunately, when we wait until the brink of death, we've missed tremendous opportunities to relieve suffering, not only patient and family suffering, but our own vicarious suffering as surgeons. You can also see there that, as palliative care physicians, we are absolutely happy and ecstatic when our patients live and go to rehab. So here's your first question. Hope the technology is working. It does appear to be. And of course, there's crowd psychology. You get to see what everybody else has answered before you. So a little bit of a trick question. The correct answer is D. Ethics literature is very clear that patients ought to make decisions based on values and preferences. Preferences are not wishes. Preferences are context specific, and they are also based on values. If you haven't read this book, it's awesome. Henry Marsh, British neurosurgeon, now retired. And it's not just about his patients, it's also about him and his family members. Here's your second question. You guys are fast learners. Nobody's answering C. Really, A, B, and D are all correct. There's a group of psychologists that came up with a a thing called terror management theory. And they claim that existential fear affects every decision every human being makes. Not sure they're wrong. The two things that seriously ill surgical patients, like, such as those who have had recurrence of their cancer or advanced malignancies, are uniformly choosing between is life and death. If they choose surgery, they believe they're choosing life. If they don't, they believe they're choosing death. So they actually don't think they have a choice. This has been borne out in the literature, mostly with emergency general surgery patients at Harvard. This is usually not a big problem for patients with cancer when they first come to see you. Everybody, you, the patient, the family, is on board and hoping for a cure, or at least living longer, or living better, or both. When this becomes a problem, in my experience, and with cancer, is with recurrence or progression, because providers rarely revisit values, fears, suffering restrictions, and patients are still clinging to their original hope of a cure, which is now a false hope. I'll pick on the medical oncologists a little bit. Over 70% of patients receiving palliative chemotherapy think it's curative. How does that happen? It's just a slow slide from primary chemo to secondary to tertiary. I took care of somebody recently that was on 7th line chemotherapy. And nobody ever really sits the patient down and says, hey, we're in a different place now. Let's talk about what matters most to you again. So this is why there's such a thing as what I call crosstalk. We're actually operating out of different hemispheres. Informed consent is not achieved by a mere transfer of information. It requires that the patient or the surrogate process the information. The left brain is where we practice evidence-based medicine. I suspect 90+% of the talks that you'll hear during this Congress are left brain based. Unfortunately, it is out of touch with where our patients are. The left brain is where we pay narrowly targeted attention to fixed details that we need to manipulate. Like surgery, it's just like operating. The left brain has serious weaknesses, though. It's overly positive. It has an optimistic outlook. This is due to dopaminergic rewards. It has poor insight. It lacks empathy. It can't see the big picture. Frankly, it sees the world like a predator. The vast majority of our patients are employing their right brains. Why? Because A, they're experiencing an existential crisis. They're concerned that they're going to leave the planet. And also because the experience is new to them. New experiences, all of us, all human beings use our right brains for new experiences, but these experiences aren't new for us. We've already done X number of liver resections, et cetera. So the way to fix crosstalk is to attend to patient family emotions. Most importantly, rather than trying to continue to drag them into our left brain process and give them data as if they can make the decision as if they're going to the grocery store to pick out a toothbrush, as Henry Marsh says. We need to go into their right brains. We need to figure out how to listen to their world. This is a video. Hopefully it'll work. Here we go.
These are hard conversations. I've blown them many times myself. I've not known what to do. And with this study coming out from the Mass General where the patients had seen a palliative care physician, I realized that the gain they'd gotten was that really they'd seen 6 people who knew how to, that's the staff at the Mass General for palliative care, that they'd seen one of these 6 people who knew how to talk to them about the end of life. And so what I did was I went to those doctors and just said, I'm really bad at this. If you had to make a little list for me of what it is that I should talk about with people facing these problems, what would you put on that list? One of the doctors that I spoke to was a palliative care physician at the Dana-Farber Cancer Institute named Susan Block. And Susan encapsulated it, I thought, the best for me, at least in a way that I could use. She said that there were 4 things that she has as a little mental list in her head that she wants to talk about with a patient who's terminally ill. Number 1, do they know their prognosis? Number 2, what are their fears about what is to come? Number 3, what are their goals? What would they like to do as time runs short? And 4th, what are the trade-offs they're willing to make? How much suffering are they willing to go through for the sake of the possibility of added time? That list was really interesting to me. It was not a list asking, do you want a ventilator or do you not want a ventilator as you come to the end? Do you want your heart shocked? Do you not want your heart shocked? Her point was, if you tell me the answers to those questions, I can make a recommendation to you that says, you would not want this toward the end if these are your goals. Our misconception is that the conversation is about hard choices. Really, it's a conversation about asking people about what they want to look forward to as time runs short and what they fear the most. And the second misconception is that it's that arriving at what we want at the end is a kind of epiphany. Sign here, do you want hospice? Do you not want hospice? It's not an epiphany, it's a process. It's a series of conversations and ups and downs as we go through a very hard series of sequence of things that happen to you as you become ill and have things come to an end.
So if you only take one point from the entire talk, this is it. I read this article and, you know, I'm not up here preaching. I've made these mistakes hundreds and hundreds and hundreds of times over the course of my career. When I read this article a couple of years ago, I realized that I have been using the word want a lot. And I challenge you to remove that word from your vocabulary when speaking to patients. As soon as you use that word, we're no longer in a collaborative process with your patient. There's no space for deliberation. Want essentially asks the patient or the family to make a decision now. It short circuits a good shared decision-making process. Ironically, want does not honor patient autonomy. Autonomy is not based on a binary yes or no choice. It requires that patients reflect on their values, the values that undergird preferences and decisions. So rather than offer them options, what I call a la carte medicine, as if our patients were at a restaurant where, frankly, they've never experienced any of the food, determine their values, their fears, their suffering restrictions, and then enmesh them with the evidence that you know, with your experience, and make a recommendation. In order for it to be ethical, you have to talk about the alternative treatment pathway and why you're not recommending that. I'm not recommending that we put a gastrostomy tube in your mother because you told me yesterday that your mother said, if I can hear her say once, I can hear her say it 20 times, I will not have my children changing my diapers. That's all I needed to know. To say, no peg. So I frequently start out, and I realize I have an advantage because I'm a consultant and I'm not in the trenches of doing surgery anymore. But I frequently start my conversations out with my patients that I'm consulted on with. Tell me about you as a person. No, not the medical stuff. I've talked to your doctors. I've read your chart. I want to know about you as a person. And their jaw drops. It's the first time they've ever been asked that question from any clinician. What matters most to you? What are your non-negotiables? What I call non-negotiables. That's those unacceptable treatment burdens or suffering restrictions. Going to a skilled nursing facility, would you be okay for a little while? Would it be all right if you spent the rest of your days there? Oh, you're not willing to go to a sniff for one day? That affects what operation I'm going to do or even offer. The big picture prognosis also, it's not the G-tube will fix the dysphagia, which frankly it won't. It's the picture, the big, huge picture that has their mental status, all their comorbidities, their frailty, what's their likely functional outcome, all of that kind of thing, because that matters a whole lot more to patients than survival statistics. Okay, come on. It's funny. When I present this to medical doctors, they laugh. Very interesting study, 180 patients who had serious illness and were admitted to the hospital. They were all 60 years old or older. And they screwed up the Likert scale. As you can see, neutral should be the middle point, but they put neutral down almost dark blue. Nonetheless, more than half of 180 seriously ill adults, 60 years old and older, consider bowel and bladder incontinence, relying on a breathing machine to live, and being bedbound a state worse than death. Over a third said full-time confusion, relying on a feeding tube, and needing full-time care was a state worse than death. You need to determine these things before you undertake a big, high-risk operation. This is a study that comes out of University of Wisconsin. They have hundreds and hundreds of transcripts of conversations between surgeons and families that they have analyzed, at least some of. And you can see there that the model that we use as surgeons, we're fixers. We use the I think I can fix it, or I don't think I can fix it. One of my surgical palliative care colleagues asked me, she said, how did you think about this? I said, I'll be honest, before I even walked into the room, I knew whether I was going to offer him an operation or not, and I knew what operation I was going to offer him. But that's not shared decision-making. I haven't discovered the patient's values and their suffering restrictions and their fear. So how could that be shared? So again, I'm not throwing stones. I'm in the glass house. I had lots of broken mirrors, believe me. So just want to kind of contrast 4 different types of decision-making communication approaches. And we're going to start over on the far right, the directive or paternalistic model. It's essentially a tell model. Doesn't happen that often anymore, but it still happens. It goes something like this. Unfortunately, I have a lot of experience with this type of problem. And I think, although you might incur significant risk either way, doing a complex operation to fix your cancer is going to be your best shot. It's just better till maybe we should just wait until you get some more nutrition and your nutritional values improve before taking you to the surgery, because it's going to be challenging. So now if we move over to the left, the informed choice, which one palliative care ethicist calls radical autonomy. That's kind of a telltale ask. That goes like this. Unfortunately, your cancer is pretty bad. Without the surgery, you'll die from it, and you're not likely to get much better before you do. Even with the surgery, there's still a chance of dying. And you're going to have to go to the surgical intensive care unit afterwards. If that happens, it'll make you even weaker than you are now. Do you want me to schedule surgery? Then the facilitative, or what I call protocolized medicine approach. It's a little closer to shared, but it's not shared. That's assume, tell, ask. You're making assumptions about what the patient's values might be. And you know your protocols, of course. We all know them all. And if we don't, we can look them up, NCCN guidelines. Assume, tell, ask kind of goes like this. If you were to say, I can't possibly have an operation, then we can do our best to work around that. But you have a significant risk of dying from your cancer without it. If you were to say, I really want the operation, say, so that I can return to spending time with my family, then we can plan on getting your nutrition a little better. But the risks of complications and dying, there's a risk of dying with the surgery too. Shared decision-making, which is the ideal, which I almost never see, by the way, is ask, 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 tell. Ask, tell, ask. What? That goes something like this. What I hear you saying is that you're simultaneously hoping to regain some strength so that you can enjoy more quality time with your family, and that you're very concerned about bigger setbacks. As we continue to explore your hopes and fears and unacceptable suffering restrictions, I'm confident that I can make a recommendation that best aligns with your values. I'd like for all of us to be on the same page before taking any big steps. Would it be helpful if your partner came in and discussed this with us next week? We didn't come to a decision with that one, did we? But you're listening for and contextualizing their values, and then you're intermeshing that with what you know in your experience and all of your very importantly understood Kaplan-Meier statistics. So be honest. And that's completely understandable because we haven't learned how to do this, right? We all know how to operate, haven't learned how to do this. And unfortunately, communication skills are just, or fortunately, whatever, they're just like operating. It's got to be experiential. You can't learn it from a book. So this is ask, ask, ask. You got to figure out their values, their expectations, their fears, their suffering restrictions. Then that fourth ask is ask permission to deliver the prognosis. This is worse than delivering bad news. This is way worse than delivering bad news. Bad news, patients are expecting. They're coming back. They had an image. They had a biopsy. They're expecting the pathology report or the imaging study report, but prognosis is whether they're going to live or die or how long or what it's going to look like. This is as impactful as major surgery. So ask permission before you deliver it. Then the tell is the prognosis. And then the rest we don't really need to talk about, but that ultimately that next to last ask is, can I give you my recommendation? That equalizes the power. Every time you ask permission, you're equalizing power. Then you tell them your recommendation. As I said, you tell them why you're not offering the alternative, whatever that is. And then that last ask, you're asking for their understanding. So tell me, how are you going to explain this to your son when you get home? If they don't have understanding, you haven't done an adequate informed consent process. So this is a busy slide, I'm sorry. And we're not going to talk about any of the stuff in the yellow, but there are what I call 3 perilous pivot points. These are the time, you don't have to do this with your lap choles and your appendectomies, okay? But these are the perilous pivot points. Preoperatively in a high-risk patient or high-risk surgery, life-threatening disease, old, frail. Post-op, after complications, poor outcomes, but prior to any rescue plans and progression of disease, which is what fits this talk with malignancy. Every time there's progression of disease, that warrants a re-goaling conversation. We're not in the same place that we were 3 years ago. And then you go through all this stuff. Ultimately, you wind up with one of 3 plans: curative intent surgery, palliative surgery or a procedure, or shift the focus to comfort. What do you know about hospice? In the curative intent surgery, particularly if you're at a perilous pivot point, you need to discuss your contingency plans preoperatively. We're going to do the Hail Mary, okay? I've been there a million times. We're going to do the Hail Mary. What if the receiver drops the ball? What if you're still on a ventilator 4 days after surgery? What if the surgery doesn't work? And there's a million times where we as surgeons know this going in, right? Ischemic bowel, you name it. What if? Figure out your contingency plan, your plan B, your exit strategy before your patient is intubated, anesthetized, delirious, et cetera, et cetera. You can't have a nuanced care goals discussion with them post-op. So you've got to talk about it with them pre-op. Stay out of the weeds. What are the weeds? Anatomy, physiology, pathophysiology, oxygen saturations, blood pressures, ventilator settings. Stay out of the weeds. We train our surrogates, unfortunately, to get interested in the weeds, and then we just have to give them another report. Oh, well, we had to go up on the PEEP or whatever. Don't forget, patients and families are in their right brains and under extreme existential fear. You have that knight's armor. That shared decision-making. It's messy. So before my last slide, I'm just going to have to, an activity, if you're interested, maybe we'll do a little activity so we can grow our right brains a little bit. But I want to thank Rick Green, General Surgery News, Don Nakayama, American Surgeon, Southeastern Surgical Congress, for all the support they've given the Surgical Palliative Care Society. I'm hosting a breakfast on Monday morning if you're interested. Residents can join for $25 a year. Medical students can join for free. We have a student and in training committee, and we just got off the ground last year with our inaugural meeting and have about 100 members.
Great to see you. Thank you. The reason we talk so much about and do so much improvising is that we've come to see that it's foundational. Okay, now he's leaving. That there's something about the experience of improvising that opens you up to another person. So that then when you turn to somebody else, whether it's an audience hearing you talk or a patient, you fall into contact with them in a very personal way. There's an intimate relationship between the two of you.
And learned about lungs.
When she laughs, she's not laughing.
Oh.
Communication is a two-way street. A full three-dimensional presence with the other person is what improv will bring about. When things happen that you don't expect in life, and you've had enough improvising to get you used to that, those unexpected things become welcome. They become opportunities. That's where the gold is, in the unexpected. Life is uncertain. And if you stop the uncertainty in order to have control over it, you're missing on all the gold. Okay, it's a balloon now. So this accustoms you to welcoming the uncertain. You surf uncertainty rather than avoiding it. And that's why we concentrate so much on improv.
So who likes uncertainty? Right. I know. I hate it too. I can't stand it. And so much of what we do is uncertainty. That's Alan Alda, and those are medical students. And he says, life is uncertain. That's where the gold is. So if you want, we can play that. We can grow our right brains. You can all stand up, find a partner, stand 6 feet away, and we can do that for a minute or two. No? It'll be the first time you've ever done this at any surgical meeting. And I guarantee when you call your loved one, this is what you'll talk about.
So what do we have to do?
Yep. Just stand up, find a partner. So what you're going to do is you're going to stand about 6 feet away from them, 6 feet and 1 inch. I don't know. Are we still in the COVID era? And I'll partner with you if you want to come up here. Okay. So one person, so you're going to stand there. You're going to make eye contact. You're going to be still. One of the two of you is going to start to move, and the other one is going to mirror them. So if one arm goes up, the mirror arm goes up. We'll do that for about a minute, and then we'll switch leaders. So now, without any warning, whoever has been following can start leading. Very good. Thank you for that. I heard a lot of laughter, which, by the way, proves you were using your right cerebral hemispheres.
Thanks, everyone, for coming. Enjoy the rest of the meeting. And thank you to the panelists. Thanks so much. Appreciate it.
Reform, yes, reform. Yeah, I hung up my scalpel 6 years ago.
I know, I saw it.
Yeah,
The idea of the period. Yeah. SIG is very powerful for very.
I'm gonna